Hey, we haven't done one of these in a little bit for a number of different reasons, where I haven't had time to actually record this immediately after writing this up. So we've got a couple other ones in the can, but I'll have to do it by hand, which we'll do over in the other office. Keep in mind, when we look at these really messy things, this board was empty, and a lot of this is for me during the session, so I can try to keep my thoughts organized, but also keep a running communication with the patient. But also to actually even film it like this, to reorganize my thoughts, to be critical of what I think and what I thought and where we're going to move forward. And none of this is even for the patient. I don't think my patients are going to watch this on Instagram, but I can at times send them this offline just so they have an understanding of what we are trying to do. In this case, significant management of primarily medial epicondylitis, which we know is tough, but MRI also shows some business on the lateral side. So everything that we see over here was really the initial discussion of where he was at and trying to understand what things are and where they're going. Over here, we've got our typical SFMA, and then maybe we'll film some other videos down the road on actually how we started to put some of these things in place. So let's talk first. So now I was able to get the MRI before seeing the patient. Medial side is significantly more aggressive in the pathoanatomy, and the biggest piece that already kind of says the horse might be out of the barn is that there was a 13 millimeter resection of what is being termed the pronator flexor mass. So if this tissue mass is off the bone, there's a challenge. There's a significant challenge there. I don't know enough if 13 millimeters is significant to just throw your hands up and say, let's get this done. But we always have to take the assumption that it is not insurmountable. We do know how we can train connective tissue, particularly if we're invested in this for a very, very long time. And additionally, I had no confidence, particularly after talking to this patient before seeing them in person, that they were getting a full view of everything that could be contributing not only to the problem, but to the solution. And that's where we get into this list over here. So now, patient had seen the doctor, a physician, back in June, PRP. He's very not confident in that because it did nothing. And it wasn't right then and there, but as a side commentary, I'm very favorable to PRPs. Did you do it in the correct area? And did you do it in conjunction with other things that need to happen? Meaning you're pissing in the ocean, but with a PRP, if you're not applying proper therapy, rehab, activity modification, etc., I don't know why any passive approach would be of value if you're not going to run plan B, plan C, and plan D. I think something else to consider as well, given the magnitude of any given pathoanatomy, and I have been in surgeon's office when they've done PRP, and of course never in front of the patient, but to see that when the tube is taken out, it's not nearly as high as you've seen it with other people. And if you take the same amount of blood and you spin it, and it doesn't even have as many or as much platelets as what is ideal, well, that should speak to the potential effectiveness of the PRP. So maybe PRP does work, and you have some type of constitutional issue where you have low platelets, so when they pull your blood and spin it, there's not going to be enough platelets to solve the problem of creating this new inflammatory process. So PRP, very, very favorable. Patient was interested in understanding. I use the example of if you and I are at a restaurant and we're talking, and then the fire alarm goes off, but we know it's a false alarm. After a while, we don't hear the alarm anymore, and that's kind of how these chronic soft tissue injuries and issues can value a PRP, because if the platelets don't hear the alarm, they're not going to come to the area, release fibrinogen and start the proliferation process of that inflammatory response. So you take the blood, you turn the alarm on through this machine that maybe didn't exist 20, 30 years ago, and all of a sudden you inject it back and those platelets are ready to work. But if you don't have a lot of platelets, maybe that's why it doesn't work as well as not being a part of this big inclusive process. He went to see a more skilled physician, surgeon. I've retracted the name because it's someone that I'm very closely connected with. And this was much more positive, where the surgeon did not recommend a surgical procedure and said that, not exactly telling them how, which I don't think is the problem, but correctly suggested that this could take a very, very long time. I believe the physician said it to take a year. I don't know what a year means in terms of what is a long time to different people, but indeed, if we are using the proper protocols and the proper complete approach, yes, remodeling connective tissue, particularly at these very, very aggressively pathological tendons, tendinosis, etc., tendinopathy, it can take a very, very long time. And in terms of describing if we use ultrasound and start to look at what these tendons look like, just for illustration purposes, there's no suggestion that this is exactly what they look like, but in a healthy tendon where the collagenous tubules are directed in the direction of your movement strategies, 100% of force, ideally is 98, units of force, meaning you're not losing anything as the force, goes through the tendon. But when the tendon is pathological, 100 units of force is only 54 units. And this is all make-believe just to illustrate things. But that's where not only is force production impacted, when the force goes through this tendon that isn't ideally aligned in the way connective tissue can be aligned, then all of a sudden, you also have a threat perception because it doesn't feel right. The body doesn't perceive it properly in terms of what this force is doing in this force transducer of a structure in the tendon. And then the arrows would suggest that if we can apply the proper strategies, we should be able to get this to look like this or closer to that. You can always quantify that through musculoskeletal ultrasound. So moving forward, Voltaren doing nothing, so that's fine. Now, I said that there's really going to be three ways that we unravel this. Number one, we have to find what I just described off the top of my head as contributing biomechanics. That's where we're going to look at the whole body, because to have these overloads in the elbow, it's very, very uncommon to not have some kind of inefficiency at the shoulder and or the neck and or the thoracic spine. Unless I say this is the same line all the time, but unless Triple H blasts you with a sledgehammer right in the inside of your elbow, this was something that happened in conjunction with other joints and other tissues being involved, other motor strategies being involved. So all of this comes into play as it relates to this. For this individual, we can look at that as foundational. We can look at that through training choices for fitness, and then we would also have to look at that through tennis and golf. And tennis and golf, I think there is enough evidence and enough, at least clinical pathways, to best be able to be like, okay, if you don't do this well, this might be what you don't do well in your swing, and then potentially load up these particular tissues that are very, very commonly pathological in golf and in tennis. And if you're a tough individual and your threat perceptions really don't shut you down, hey, that's just part of the recipe. We'll work with that as long as we understand that, okay, if you're not going to stop provoking things and antagonizing this rehabilitation or therapeutic approach, well, then at best, we're just going to slow things down. So that's something that we would need to accomplish.